Perfect. So good evening. Welcome everyone to this week's COVID-19 Primary Care Update. A big thank you to Adelaide PHN for hosting tonight's webinar, and very grateful again for such wonderful speakers that we have here. This evening we have Dr. Chris Moy, the AMA Vice President nationally, and we've heard so much from Chris lately in the media, which has been fabulous, supporting us in our COVID response. Dr. Tom Dodd, or Associate Professor Tom Dodd, I should say, as SA Pathology Clinical Director, and you can see Tom's got his microscope there in the background, so we can see he's a real life pathologist. So thank you, Tom, and always great to have you here with your expertise. Dr. Jenny Gould, who does a wonderful job as the lead of our GP assessment team, managing COVID for the past 20 months, Jenny. So phenomenal. You've been an absolute star throughout this, and words of wisdom constantly from Jenny. So a big thank you to all that you do for us. And we're really looking forward to hearing about the clinical pathways tonight. And a big thank you as well to Crystal Myers, who's done a great job as well with Adelaide PHN and a support for so many practices across Adelaide. So we've got a few areas we're going to talk through tonight, and I think different presentations have been submitted through to Crystal for us to start and talk through. I think I'm going to kick things off. Is that right, Crystal? The first bit of the update, and then we'll progress along?
Yes, lovely. Thanks, Emily.
Wonderful. I think for some reason I'm only the person that can be seen. Bridget's just posted in the chat, so hopefully my face is not too big on your screen, Bridget. So we'll progress now and start with the slides, and then we'll move through around some of the key areas, and then leave plenty of time for questions and answers. So please post them into the Q&A so we can link up responses to your questions rather than in the chat box. All right, so I'm just going to share my screen now. So hopefully you can see that there, the presentation. Fabulous. All right. So what we're going to do is talk through just a little bit around where we're up to, and particularly I know lots of conversation at the moment with the current variant and where we're heading. So key areas really to talk through around PPE issues and costs, pressures on the system, including in general practice, the vaccine booster program, and perhaps some changes that we may see there. Antigen tests, and we know that Tom will go through a little bit about that as well as we move along through this evening, talking about the variant impacts as well. With the Omicron variant, of course, that's quite concerning at this point in time. We know that there's absolutely increased risk of transmission, not quite understood yet around health impacts because of the fact we know that people tend to deteriorate in that second week, so we'll know more soon. And then also around exposure matrices, and we talked around that last webinar, but we're going to focus a little bit more around general practice and some of the areas that have come up and some of the concern areas as well. And then I thought we'd just talk a little bit about the visitor guidelines as well, and what we're putting in place in the hospital system, so that can perhaps provide some guidance as well into the general practice space around visitors and how to deal with unvaccinated visitors as well, which we know is an ongoing area of concern. So we'll start first of all with the PPE issues as well. So we are very much acutely aware of the current constraints around PPE and the costs associated with PPE. And this has really been emphasised with the exposure matrices as well, which do highlight the role that PFRs, N95s do play in terms of reducing that risk of being furloughed as a result of potential exposure or then exposure to someone with COVID-19. Now, we acknowledge the fact there is the national stockpile, and the PHNs are absolutely going to be able to assist with providing PPE out to GP practices as required in the event of an outbreak, and different requirements as well for the GP respiratory clinics. But we know that there is an absolute immediate pressure. So we were pleased that SA Health's able to supply out at cost price for PPE. Unfortunately, we can't give it out for free. We wish we could, but there is already a Commonwealth role in that space that we need to be quite mindful of in terms of where we step into different areas at SA Health. And we're very happy to provide that out into other areas as well of primary care, particularly if someone is seeing, it's part of the role and responsibility to see someone with respiratory symptoms. So we want to make it as easy as possible for people to get access to PPE. So this includes the face shields as well, and other PPE requirements that you may need within your practices. In terms of the fit testing as well, we know this is an ongoing issue around fit testing. Fit checking. So the minimum requirements are fit checking every single time you put on your mask. And there's some great videos online. The New South Wales Clinical Excellence Commission does have a really good video to watch about how to fit check every time. And then, of course, for that added layer of protection, fit testing is really important, particularly if you are swabbing someone and you're constantly in that space and wearing PPE for long periods of time. And we are very happy to assist where we can at SA Health around fit testing. If you've got particular in particular areas, we can link you in with the LHN with their health, work and safety groups to try and organise for fit testing for you. We've also got the Carlin has put forward that they're very happy for AusFit Test to be able to support as well in this space with AusHealth. And I think Mel Smith, we put that out in a GP update a couple of weeks ago to try and help as much as possible to get fit testing as easy as possible into the community, and noting as well that we know that people had to change masks recently because of supply, so there is that need to refresh often the fit testing requirements. So we'll do what we can. We've got to support each other in that space. People say, what about the mask, the goggles? What does it mean? You know, how does this all work together? We know that eye protection does add that added layer of protection. Now that's both the safety goggles, the glasses, the wraparound glasses with the sides, particularly for prescription wearers, and also the face shields. Now that's part of the matrices. But if you are swabbing and you're at one of the sites where you're, repeat wearing long wear PPE, we absolutely also wear the goggles and the face shields over the top. But when we talk about the matrix, we are looking at a level of PPE required to keep you as safe as possible. And so it is just either the face shield or the goggles in those particular situations. I think that covers the PPE, but very happy to post and answer questions in the chat as well as we move along. And I know that Chris may comment on this as well. But we are really trying to push very hard at the Commonwealth space to get more access to PPE from the stockpiles. Ongoing pressure on the system. Now, we're very much aware that that it is very difficult at this point in time with the changes as well, the border reopening, that risk and anxiety in the system around potential cases in the community and the pressures on the system. And we've seen that with the women's and children's having ramping last week, which is just unheard of, the women's and kids having ramping. There has absolutely been a shift in how we are seeing people that pivoting now to telehealth. And we have to do what is possible to keep everyone safe. And if that means transitioning further to telehealth, then that's absolutely what needs to happen. Finding alternative pathways of care, referring on to the GP respiratory clinics, to the testing sites. We've had phenomenal testing times coming back through SA Path. I mean, we're talking 5 hours. I mean, I've seen results come back for Vic Park for many people. So it's incredibly quick to get that test, send someone down, get the test, get them in the next day and have them examined for their symptoms. Really easy ways that we can try and reduce the risk as much as possible without having to decline or not deliver care to certain groups, and particularly to your regular patients. Of course, you want to be able to provide that level of care to them. So important we have alternative measures in place. But yes, I just want to say a big thank you to all the GP practices who have been managing and balancing all the vaccination and now, of course, the new pressures in the system with community COVID potentially on our doorstep. Vaccine boosters have been very topical in conversation and will continue to be more topical as we move forward into the variant now that we've got the variant, the Omicron variant. So we do know that that is currently being reviewed in terms of the timeline for that third dose, for the booster dose. At this stage, it's still 6 months after the second dose, but there is active review happening in Otago as to whether that will be brought forward to 3 months. At this stage, it's still the Pfizer vaccine being given. We're really hopeful that we will see Moderna come on as well from a booster point of view, as we do know that there's some really good data to support Moderna being given. And then, of course, we're hoping that Novavax as well will come on in the early new year as well to support the vaccine program. Very hopeful that we'll see kids 5 to 11 be offered the vaccine by the end of the year. So we're hoping that's looking more and more promising that will happen, and we're just waiting for more real world data to come through. But strongly encourage you to get your booster vaccine. I've had mine yesterday, not feeling so great today, but knowing that I'm doing my part and I'll feel much better if I get boosted now than what I would if I had COVID. So it is an important reminder for us to all remember to do that. And add that added layer of protection and just look at the real world data coming out of Israel. The next area probably we've been focusing a lot about here in SA Health is on antigen tests and making sure that we can make it as easily, as accessible as possible, particularly for our regional rural medical communities who absolutely will need antigen testing to support them as we move forward part of the pandemic. And I won't talk any further about that because I'm sure Tom will discuss where we're up to in that space, but we're actively working on revising that direction this week so that we can allow for antigen tests to be undertaken in certain circumstances. Now, of course, the variant, I think this was all just a bit of a depressing news on Friday when this came through and there was emergency meetings being held, that really disappointing. But of course, it's not that surprising that this has happened when we've seen such low rates of vaccination in some areas that has resulted now, we know, in different mutations occurring. There is concern around what impact this will have with vaccination, and there's active testing happening over the next 2 weeks to really look at what role vaccination will play in testing around that with the variant. So we're very hopeful that it will provide a good level of protection in terms of severity of illness, and we don't really have indication that just result in a more severe illness, just been anecdotal reports coming out at this stage. But we are very hopeful that the vaccine will still provide that level of protection. It's just not quite clear around transmission risk at this point in time, but really hopeful that we'll see some changes there. And as many of you be aware, we did make changes to our border restrictions here in South Australia. So we did move to a 14-day quarantine period for international travellers. We'd only been at 7 days for 5 days at that point in time. So unfortunately, we have now had to increase up to the 14 days. And the reason for that is we are worried about exposure on flights at airports in particular. And we do have, of course, quite a number of flights that come through the Middle East where we have seen that there has been cases coming through. So we do need to be incredibly mindful of that. So disappointing, but unfortunately not that surprising given the low vaccine rates globally that we're seeing in some particularly more vulnerable areas. And then probably the final area I'll talk through is around the exposure matrices and where we're up to currently with those matrices and what do they mean around vaccinated, unvaccinated, and there's been lots of questions in that space. Oh, I feel like I'm rattling on and talking a lot. So we'll move through some slides and break it up and then we'll move on. So vaccination, I mean, this is the messaging we're trying to get out as much as possible. And so really good to try and, really emphasize this to your patients around this is where we see ourselves heading. We've got the TTIQ, the public health and social measures, and vaccination. And all three pillars are really critical for ensuring we can live with COVID in a safe way. So emphasizing contact tracing there as well and staying home when sick. We know that there'll be fewer people required to quarantine as a result of the new changes that have come in, and we've seen that already, significantly less numbers with the current cases that we have, and we've got 7 active cases here in South Australia at this point in time. We know that vaccinated people are only required to do 7 days of quarantine, and really pleasing to see all the cases we've had here, we've had in our adult population group that have had COVID have been vaccinated. So very pleasing that we haven't had any unvaccinated cases here since we reopened the border in adults. Noting we did have 2 kids, and of course they're not vaccinated under the age of 12. We've got the new travelling to SA system, and you probably heard about this, which is Entry Check, where you apply online through the portal. It's taken away the whole SafePol application process to make it really easy and streamlined, and that's still going through some teething issues, but certainly it's seen really great responses so far. We've had over 18,000 people use our health check system already, which is the system that allows you to show your testing, put your symptoms in, and also if you're in a quarantine, do facial geolocation mapping, which enables us to have that added layer of compliance. And then we've got the COVID safe check-in. And I'm sure many of you have already put the vaccine passport, the Vax Check, that has been loaded into your QR check-in SA Gov app. Took a bit of time, but I got there in the end. So if you need any help at all, let us know. We can send you through the instructions. So as I said, we have the health check system, which is the old home quarantine, and we've transitioned that over the past week into this new system, which will enable us to then expand into managing people with COVID-19. Fortunately, we don't have anyone in the community at the moment. Everyone has gone into the Tom's Court positive facility, but we know that as soon as we have someone who is suitable to stay at home, then we will absolutely be activating our new home quarantine COVID response care team for those people. And then that takes us to that 85% bottom group where we know that That's where the majority of people will be managed very safely in the home, and lots of work happening in the regional rural space at the moment to really finalise some of those plans. So big thank you to all the GPs and the Country SA PHN who have been involved in the planning for this. Now, this is probably the last thing I'll talk about before I go on to the matrices, is just around the visitor restrictions and screening. And so this was just put together around where SA Health is heading in terms of their visitor restriction guidelines into the hospital system. But I thought it was quite helpful, just more so for GP practices, particularly around, well, what are some of the things that maybe you could be considering for your practice in terms of having visitors? And we know that there's certainly changes that you can put in place around not having children come in if they're visitors. So unless they're coming in for specific support reasons and can't come in for other reasons, have to come in because there's no one else to look after children, just ways that we can try and minimise the risk as much as possible. And talking around unvaccinated visitors as well. I mean, this gets a little bit complicated around PCR testing. There's been a lot of movement in this space around, do you PCR test your patients before they come in, elective surgery patients before they have their surgery, and then also around visitors. So I think a lot of that's going to be determined around, Tom, and the capacity across SA Pathology and the two main private labs around whether we can support all this PCR testing, what the role of antigen testing is moving forward for these groups. But I think that there is really an area that we do need to further explore, and hopefully these visitor restrictions and the screening just provides a little bit of guidance of where we're heading from the SA Health perspective when then you're considering your own facilities and what you may need to consider as well to impose for additional people coming into your practice who maybe don't need to be there, and to try and reduce down that risk as much as possible. Now, unfortunately, didn't quite copy over as well as I would have liked these matrices into the slides because they've sort of expanded in the format that they're in. But wanted to emphasise here when we talk about vaccinated and unvaccinated in these matrices. Now, these are the exposure ones. We've sent them out already online. We've talked a bit about them at the last webinar. These are in the new format now, the new comms, much easier to read format. But what I wanted to emphasise, it's vaccinated close contacts. It's not the vaccinated case themselves or the person who has COVID-19. In fact, that plays no role in an exposure matrix in terms of whether the individual who is COVID positive is vaccinated or not. Now, we know, of course, that does play a role in terms of risk of transmission, but from the point of view of exposure, in terms of exposure, that person has already tested positive, even if they're vaccinated. So we have to keep that in mind. They're still shedding, they're still transmitting the virus to others, even if they're vaccinated. So we have to look at this from the contact point of view. Now, this is the staff member or other patients who are in the practice. And people said, oh, why do you have unvaccinated when healthcare workers are required to be vaccinated? And you'll see that in the next slide when we move here and you see the red where it moves this. Well, in fact, we do have quite a number of staff who've only had one dose of a COVID-19 vaccine, and also staff who have medical exemptions or temporary exemptions for 6 months for various reasons. So I think that's just a good point to emphasise. It's the staff member or the patient in the practice who does not have COVID but has been exposed to someone with COVID when we talk about the contact. So I hope that provides a little bit of clarity there. You'll also see around the eye protection that we have in there as well. And the fact that the case themselves, it doesn't matter if they're wearing a mask or not, because we absolutely know if someone is highly infectious, in fact, the mask may do very little to protect the person who's been exposed. Now, as we move forward in terms of this green, yellow, orange, red, you can see it's to try and emphasise as much as possible about what someone needs to do. Now, the reason why practices were said, oh, collect the details, send them in, is to try and speed up the contact tracing process. It's not to add more work to your practice. It's not to be because we don't want to do it and we want you to do it. The background behind this was to speed it up so that we can get people back in, we can get the business moving, and we can get the GP practices back open again as quickly as possible, because we know how critical it is and the impacts of financially, but also for patients as well if you're not able to open. So that's why we ask for patient details or details to be collected. But certainly the team at SA Health will be supporting you through that process. So you're not alone, you're not doing it on your own and making your own decisions, but we're putting this out there to make it really clear and easy around what would happen in the event that you do have someone in your practice, and a lot less people than what we previously had would be going into quarantine. We then go through to try and make this a little bit just easier around the distancing, although not quite as relevant in some practices around outdoor, although we've seen some great tents being put up with 2 wall tents, particularly in the outdoor areas. And then, of course, we've got car parks as well that some people have been using, but not all of us would have access to car parks and tents. But we do know that this was a particular issue raised in New South Wales. And thanks to Mel Smith, we had this included in our guidelines here because we just wanted to provide people that extra opportunity if they were wanting to set something up outside and provide that guidance as well. And then we have in terms of the overall managing risk in the public, and you can see that we've tried to, again, make it easy around what happens from days 8 to 14, particularly for vaccinated close contacts. So that's probably all. I think I've talked enough at 20 minutes, and I'll hand over now to Associate Professor Tom Dodd, if that's okay. And as I said, very happy for questions to be asked in the Q&A. Probably best to avoid the chat because we lose track of where the questions are and being responded to. But a very big thank you to all of our GPs and everyone in the primary care space, for ACSA, the Aboriginal Community Controlled Health Organisations, everyone who's doing a fantastic job to support us in this COVID response. We could not do it without you and your support. And it's tough. We see it constantly coming through online, how tough it is for everyone at the moment. And we just want to say that we are incredibly grateful for your support at SA Health. So thank you. I'll hand over now to Tom and I'll stop sharing my screen. Now, Tom, you're on mute at the moment, so hopefully we can find your slides.
There we go. That's good. So good evening, everyone. Crystal, are you able to post my PowerPoint?
I'm just doing it now for you.
Thank you very much. Not too many slides, so that's good. We can skip through to the second one. That's it. Great. So look, one of the things I've been asked about a number of times in the last week or so is what is the capacity to be able to provide that really high volume swabbing and lab testing that's so important to keep the system moving along. Obviously, last year, we had the Parafield event and then we had the Modbury event in winter. The situation then was that we had good capacity, but not nearly enough. And so we've spent a lot of time working on our capacity, the number of drive-through locations and also staffing. So we've onboarded something in the order of 300 additional staff over the last period to really add a lot more capacity. So in Metro Adelaide, we've got Victoria Park, which everyone's familiar with, going 24 hours a day, Ridgehaven out there in the northeastern area. We've also got the airport, which of course has now become extremely important as the borders open. In fact, that's now, not surprisingly, the busiest site. The other location with extended hours currently is, just jumped ahead for some reason, Laffers Triangle, which is down near Flinders, which we've extended the hours of operation through to 11 p.m, but with the option of extending to 24/7 if required. So there is really a lot of opportunity for people to get swabbed now. There's a new biggish drive-through about to open at Bordertown in the southeast tomorrow. And as Emily's already mentioned, the optimisation of the technical side in the laboratory has improved really sequentially throughout the entire pandemic, to the point now where we're putting through 7,000 or 8,000 swabs a day very comfortably. With turnaround times, I've said less than 10 hours, but in reality, on several days, it's been closer to 5 hours, and that's for 90% of the swabs completed. So many people are reporting back that they're getting swabs results back in sort of that sort of 4 or 5 hour period, which is fantastic. We're very pleased about that. So I think we've got a lot of capacity to accommodate what we need. Clearly, there is likely to be some cluster or outbreak events at some point, and we're planning to be able to go beyond 20,000 swabs a day if required. Some of you would be aware that there is going to be routine pre-operative screening of elective surgical patients starting from the 1st of December. So patients who are going to have elective surgery will now have a COVID PCR swab performed 72 hours before their procedure. So that is adding a level of assurance, I guess, to the anaesthetists and surgical units. But I actually think it's quite valuable because we'll get quite a good broad survey of the population of people who perhaps may or may not be having swabs. So actually I can see some merit in that just from a surveillance perspective as well. So we'll just go on to the next slide, Crystal, if you're able. Thanks. So rapid antigen testing, obviously, there's a lot of talk about that, and there's obviously the beginning of a lot of utilisation of rapid antigen testing. We're now doing extensive rapid antigen testing for fly-in, fly-out miners to support the mining industry. Over the last few weeks, we've done extensive training across all the local health networks in both metro and regional teaching hospitals around South Australia. So there's a high level of familiarity now with the test, and really the next thing is to, I think, just to provide some context about where it's useful. As many of you would know, the TGA has approved quite a number of different kits. The performance of most of those kits is actually good. We've done comparison studies with this Abbott PanBio rapid antigen test kit, which we think has very good performance. There's quite a lot of literature available and also real life experience from the eastern states with this Abbott PanBio kit. So people are thinking about what they may wish to use. Well, that's certainly one that SA Pathology is currently using and recommending in the teaching hospitals. The specificity is excellent. We've found that there's certainly false positives much less than 1 in 1,000. So you're not being inundated with a whole lot of false positive results, which would potentially be a problem. The way I now am thinking about rapid antigen testing is, in terms of its sensitivity, it's really, I think, a very useful test to say, is this patient infectious rather than infected? So the question is this patient that I'm about to see in the next 30 minutes infectious? And in that way, the rapid antigen test performance is very good, certainly better than 90% and probably closer to 95%. What it doesn't do, of course, because it's detecting viral protein, is pick the very early phases of the infection in the PCR. It also won't pick up all those tailing residual RNA positive cases during the convalescence of the illness. And actually, they're really in a way more of a nuisance because of the extreme sensitivity of PCR. So from a sort of clinical practice perspective in an ED department or a general practice, if the question is, actually, is this patient infectious? Are they going to infect me, potentially other patients in the rooms, my staff? It's probably a very good test. I think over time, it will be more widely used also for members of the public when the direction changes to allow that to happen, for people to say, well, I'm going to do a rapid antigen test before I visit my mother in a nursing home or a vulnerable person. And you can say, okay, it's negative. The chance that I've got active COVID right now is actually very low. So where are we at? The directions sort of got some subtleties in it. There is some testing going on, which is allowed under the direction under SA Pathology's guidelines, and also specifically approved by the Chief Public Health Officer, Nicholas Spurrier. But the important thing from your perspective is and Nick and Emily mentioned this, the direction is going to change imminently to allow medical practitioners to commence using rapid antigen tests. As I understand it, that's been essentially approved by the Chief Public Health Officer, and the drafting of the direction and the change should come through very, very soon. In the meantime, there have been a number of organisations and some groups that have been allowed to start using rapid antigen testing with specific approval from the Chief Public Health Officer. And I've included this email address here to seek approval to use rapid antigen testing. But I think that'll probably be redundant in terms of the medical profession within days, and you'll be able to start using rapid antigen testing if you wish in your practices. So it's something worth considering. Obviously, there is a cost associated with performing the rapid antigen test. The Panbio kits, I think, are about $7 or $8 each, so it's not cheap by any means. I guess people will need to think about whether it's possible to pass those costs on to patients, or how you would manage those costs if you elected to use them. One of the places that I think it might be quite helpful is if you're trying to consider whether you will or not see unvaccinated patients face-to-face in your practice. It might add a level of risk mitigation for you. So obviously we'll all get more and more experience. Now there's one more slide I think we jumped. Crystal. Yeah, here we go. So obviously the plot twist at the moment is the new variant, the Omicron variant. So as everyone's, I won't spend too much time on this, obviously as everyone's aware, it's concerning because this particular variant has a large number of mutations, particularly affecting the spike, but also other parts of the viral protein membrane. And the issues are, is there resistance to neutralizing antibodies? The changes in the spike may mean that it's got more efficient entry into the into cells when it binds at the ACE receptor site. And there is some question about whether it's has a higher propensity to evade innate immunity. So I think a lot of those things have yet to be fully established and become clearer over the coming weeks. One of the concerns was, will this variant be able to be detected by the current PCR tests around the world? And we know at least one of the genes that's used in some platforms is not detected because of the mutation in the gene. But what I can confirm for you is that the SA Pathology in-house PCR primer sets are not affected by these mutations. And I've also just seen late this afternoon that a number of the other testing platforms, the GeneXpert, the Liat, the COBAS and the C-gene tests are not impacted by the mutations in this virus, viral mutant. So that's very pleasing because that was a concern. We'll also be watching with interest to see whether or not any of the rapid antigen tests, which are obviously looking for viral proteins, are impacted. Obviously, the rapid antigen tests work with by using antibodies directed against viral proteins. So we'll just have to see whether there's any emerging literature around failure for detection of this particular variant. So everyone will be watching that with great interest in the coming days. And that's the end, I think, for me. Thank you.
Thanks, Tom. That was incredibly informative. As usual, I always learn something really, really, really critical there. And you've answered a few questions as well around which antigen tests we should be thinking about and different sensitivities associated. So very helpful. Thank you. All right. I'm going to now ask if Dr. Jenny Gould would be happy to talk through around the GP assessment team, where you're up to, Jenny, what you've been, all the work you've been doing. And I know you've been working exceptionally hard. Thankfully, we're not inundated with cases at the moment, but your team has certainly been very busy, not only here in South Australia, but interstate as well. So thank you, Jenny. Now you're on mute, Jenny.
Oh, I have a talent for that, being on mute. Can you see my screen?
Yes, perfect.
Great. All right. Well, hello, everyone. I think everyone's familiar now with the, doesn't want to move on. Why will it not? No. Okay. Oh, there we go. I think everyone's very familiar now with the GP assessment team, but just in case there's any newcomers to our webinar this evening, we've been around, we're old news now, we've been around since March last year, managing COVID positive patients and quarantine guests in South Australia. So we are looking at their medical and psychosocial care as required, and we work in conjunction with the Medi-Hotel nurses. As we move forward into our new community spread or new scenarios, I think the thing to note is that GPAT will still be there working very closely and collaboratively with our nursing colleagues. And although COVID has a very variable course, generally, as Emily has said, and I think we've heard a number of times now, that we can expect to manage about 85% of these COVID positive people outside of hospital, and ideally, if appropriate, in their own homes. And so that will be a bit of a change for us in GPAT, because currently all of our COVID positives have moved to our hospital in the hotel or Tom's Court, where we've provided that care during their stay and their illness journey. In addition, probably approximately 10% will need some extra support, and that will usually be able to be met ideally through GPAT or using our other resources. And then 5% or so will end up in acute care or needing support that the ICU can provide. Now, we know the biggest predictor of this, as we've talked a lot about, is risk factors. And so identifying those groups, and we have a process where our people who are testing positive will be triaged based on their risk factors and their symptoms and placed into a model of care. And then that will dictate their follow-up, which will be nursing calls or a combination of nursing and GP assessment calls. From a treatment perspective, it's like any viral illness. We don't necessarily have treatments we can provide, but it's about symptomatic and supportive care and managing the comorbidities associated with their illness. And these are not just always physical. There's a lot of mental health and issues around this diagnosis. And we now know that as we move forward, we've got some specific COVID, spelled incorrectly, management options that are available now for us in South Australia. So I talked a bit about the risk factors. This is taken from Carlin's document. It's a very busy slide, but really it can be summarised here. Looking at predictors of disease progression, we've got risk factors here, and we've got symptoms. So we can, even in someone who's asymptomatic, we can somewhat predict those that are more likely to deteriorate or to have disease progression during their illness, and also those people based on symptoms, specifically around shortness of breath and fever, are those that we know generally will perhaps be more at risk of not doing quite so well. So we've got that information, and as I say, that's been built into our model of how we triage people. So where do the community fabulous GPs such as yourself fit in? Well, you fit in, you are an essential part of this picture. So I can do my usual plug for any GPs who'd like to join our GPAT team. Please contact me. But in addition to that, the GPAT role is not to replace the role of the usual GP. We're providing, in this instance, as we move into community spread, and we will be managing more people in the home with their COVID illness. then we will be providing care around that COVID illness and acute comorbidities that need to be managed in that in that space. But we will be very much encouraging these people to go and continue to engage with their usual GP if they have one for their ongoing non-COVID related care. So, routine scripts, review of rashes, diabetes review, care plans, those sorts of things will still be very much in the domain of the regular GP and obviously through telehealth. The GPAT team will share our clinical records from when that patient is known to us and begins their journey in the GPAT process if they've identified a GP. And so that our clinical records will be shared on with you within 24 hours of us having interaction with that patient. So, so you very much are involved in this COVID journey, although we're not specifically requiring that you manage the COVID illness, but that relationship you have with your patients is invaluable. There is also that opportunistic, vaccine promotion that we still want you to be doing out there, reinforcing our current precautions to try and minimise spread, encouraging people to continue to present to swab for symptoms. And as we've said tonight, at the moment, we've got a really good turnaround on those. So that shouldn't be discouraging people from swabbing. And obviously ensuring that your staff are appropriately fitted out so as to minimise impact on your practice should someone with COVID walk through your door. So how do GPAT get patients? So patient presents for a swab, and then this positive result is identified by CDCB, and then they are risk assessed by our COVID response care team, or the cricket, as we have affectionately started to call them. And this is a group of fabulous nurses that have currently worked within the MediHotel system and have expanded now, and they will triage these patients into a model of care, low, moderate and high risk. And then based on that care, they will receive follow-up. So those that fall into this moderate and high risk group will come to GPAT, and they will continue to receive nursing calls of a minimum twice a day and GPAT of at least once a day. And of course, these can be escalated based on need. But for most people, they will be well and do well. And often our call is a bit of a nuisance. It interrupts their gardening or other things, but nonetheless, we will be checking in. Of course, not everyone will stay well, and we have plans for that as well. There is a process of escalation or referring acutely to the GP assessment team. So these patients will be able to escalate their concerns directly with cricket once they've become COVID positive, and then they can forward that referral to GPAT. And our role will be at all times, and certainly in these acute settings of referral, is to determine whether this person is safe to stay where they are. And so we have, there might be some additional supports they might need in place, and we are able to onward refer for those like mental health. We've got a pregnancy COVID care centre being established at Flinders for pregnant women with COVID that need face-to-face assessment. We've got the COVID kids at the Women's and Children's, which is looking at managing complex children. We have Aboriginal and Torres Strait Islander support. We've got our refugee support process, which has been working really well over the last 20 months. So it may be that we need to involve other people in that illness journey. But we also have other options. If we are identifying that this person cannot be managed just with telehealth, we will have the capacity for some people in higher risks that will be given an ICCT device, which is really a way of doing video calling. But more generally, we will have the option for COVID positive people for GPAT to onward refer to the COVID care centre. Now, these will be metropolitan, and we've got one at the RAH already up and running. We have COVID kids at the Women's and Children's ready to go. Flinders that are working on a pregnancy care one. These will also be available in regional South Australia, and they'll probably look a little bit different in all areas, but they're most likely to be affiliated with rural and regional hospitals. So we have the option to involve face-to-face assessment there to determine where someone is best to be managed, and we will be able to organise things like bloods and x-rays and ECGs, and we will be able to do the infusions with Sotrovimab and Ronapreve, so that they will be an invaluable resource for us. Of course, we will have the fabulous RAH ED, who's been the front line of COVID, as we've seen over the last 20 months, and that will continue at this time to be our point of referral to a tertiary centre. GPAT will also, at the end of this journey, we will be involved in the assessment and clearance of these COVID positive patients, and obviously as they're cleared, again, you as the fabulous community GPs will be getting a copy of that clearance, and so you'll know exactly where that person's up to. I think everyone's very familiar with viral symptomatic supportive treatments. I think, yes, paracetamol, fever management, anti-nausea medications, sometimes IV fluids are all can play a part. And now we have COVID care centres, we have greater accessibility for these things without clogging up our acute, our ED departments. And of course, we also now have disease modifying agents and post exposure prophylaxis with Sotrovimab and Ronapreve, and then of course hospital treatment with all the whiz bang wonderful things that they can do in hospital to try and support and these people while they recover from their illness. So in South Australia, Sotrovimab and Ronapreve are our two agents we currently have available. Sotrovimab is, as you know, a disease modifying agent given as an infusion really over about a 30-minute period. Ronapreve is a combination, and it can be used for disease modifying or in post exposure prophylaxis. And of course, with each of those comes a protocol. These are all the medications currently in play at the moment in the COVID world, with us focusing on these first two, and I guess dexamethasone's in there as one of the mainstay treatments that we've had all the way along. This is borrowed from Carlin, and again, I'm not expecting you to absorb all of this, although there will be a quiz at the end. This is really just to look at, Carlin have looking at triaging into mild, moderate and severe and critical illness. So you can see looking, and this is how they will determine options for treatment also. But you can see a lot of this is really around oxygen saturations. So there is a big focus on fever and oximetry in making these calls. And then you can see with all the medications, this is a summary chart from the RA about which in which triage category and which medications are to be considered for those various risk categories. I think Sotrovimab is really for use within 5 days of onset of symptoms. With the Ronapreve, you've got a little bit longer with 7 days in those people who don't require oxygen and aren't immune protected. So they're not fully vaccinated, or they have reduced immunity for whatever reason. This is just a prettier, less complex way to say the same thing. With fully vaccinated, meaning that people will have had their second dose more than 2 weeks ago. So that's how you meet criteria for being fully vaccinated. So this is the RA's management chart, if you like. So you can see Sotrovimab can be used in the disease modifying arena, and it just really points out, as we've said already, onset of no more than 5 days, not requiring oxygen, and that they've had immunosuppressed or they're not vaccinated. So there will be an assessment chart, and that GPAT will be involved in making that assessment and recommending onto infectious diseases who will sign off on who will be given these various treatments. And that will then usually be done at the COVID care centres. When we're looking at Ronapreve, it can be used in both areas. So post-exposure prophylaxis, which is given an IM injection, or in that sort of treatment or disease modifying, where it's given as a subcutaneous infusion. Ronapreve is our drug of choice in pregnant women because the first trimester Sotrovimab is not safe. And so for simplicity, well, I can't even speak, but you know what I mean, that we're going to just offer pregnant women Ronapreve throughout the pregnancy. And Ronapreve gives us the additional period of time that where Sotrovimab only covered till day 5, we have between day 5 and 7 the option of using Ronapreve. So it just stretches out that window for offering disease modifying. So that's a lot of detail and a lot of me talking, and but I think that just gives you a snapshot of where we're up to. Everybody's been working really hard to pull together models and make sure we've all got fabulous communication pathways, and that we're all really working towards keeping your patients, our South Australian community, really safe. And we thank you for all of your input. And remember, if you want to join GPAT, my door is always open. Thanks.
Thanks, Jenny. Fantastic. I want your slides. I've texted you to ask for your slides during that. They were fantastic, and great to see those guidelines being put to use around that the RAR put together. We're hoping to have our COVID community response guidelines out later this week, maybe next week, which I think will add a lot of value, and we'll put them up on Health Pathways. So they're easily accessible, but they haven't come to you yet, Jenny. So still a bit of time. So we're hoping next week we'll have them out to everyone, so it's really clear around community management and very much reflective of the New South Wales guidelines as well. All right, Chris, lots of questions coming through the chat around different MBS items, the national issues. We're all ears, ready to hear what's happening in the AMA space as well. So thank you.
I'll deal with a few of these. So look, I just wanted to these are quite useful little documents, and if you like, I'll send them through Crystal. This is actually in focus, the summary of the data about what happened in New South Wales during the Delta outbreak, and particularly at its peak. And the main thing that came out of it was that essentially that those who were unvaccinated were 16 times more likely to end up in ICU or die. And that those at the peak, there were essentially a person who was unvaccinated was 10 times more likely to catch the Delta strain during that peak. So they're the two key numbers which are quite useful, because a lot of you sometimes have, and I know I've had various stages trying to talk about the fact that the vaccines do protect against serious disease and death, but in fact, when you actually look at the numbers, and this is a really good article from Christopher Baker in The Conversation, it's actually on the Doherty website. Essentially, a person coming through your door in an endemic COVID environment, the person who's unvaccinated is 20 times more likely to be the person that brings COVID to you or give you COVID, because it's 10 times more likely that they'll catch it, and also they're at least probably double more likely to transmit it, even compared to a person that's vaccinated. So that's the sort of data which is quite maybe useful to explain to patients about the thinking behind some of the rules. I've already been told that I'll be taken to the Human Rights Commission for putting out this data, but they'll by somebody who felt that there was discrimination, but it's fact. I've seen some questions about children. So really getting back to it again, I'm going to go over this again. I spoke to Margie Danchin from the Murdoch Research Institute for Children, again, just to confirm what they're saying at the moment. And essentially, COVID, again, is generally not a severe illness in children. The main children who are really, unfortunately, affected are those coexisting illnesses such as severe obesity or things like cerebral palsy. And they're the ones that have had the biggest complication rate. But generally, for most children, they do not get severe disease. They do not die. And the long COVID data, from their point of view, is that it's still quite rare for long COVID, although the data on that is a little bit rubbery. Overall, there is a good reason to vaccinate, and that's really to stop outbreaks in schools and the secondary benefits of not preventing outbreaks. Now, with respect to what's happening, there was a question in the chat about what's happening with the vaccinations for children. So at the moment, the US is really getting some good data about the second doses at the moment. And I think they're up to about 3.5 million children vaccinated now. And the data is looking extremely good in terms of a very low risk of myocarditis, or very little of it. And that's about 3.5 million people. The final data will be coming out, I understand, about mid-December, and I'm pretty sure that the TGA are just waiting on that before approving it. Then it's a question of getting the vaccines out there. Now, the biggest problems that I think I've said to you previously is the issue about the very tiny dose, that 10 microgram dose, which is a third of the dose. So I've been to meetings at Atagi about it, and this is a really huge technical problem, and they are extremely clear that they will not be using the current bottles because it's just get too confusing, and the chances of mistakes are going to be high. So it is very likely we'll be heading towards these new bottles from Pfizer with a orange top, which will mean that it will end up with a 0.2 mil, I think, volume to inject, which is still much better than the 0.1 mil volume, which has, you just can't push that sort of dose through, and the percentage loss in the needle and the syringe is potentially very high if we just use the current concentrations. So probably look out for it. Now, just speaking to her, she's a bit more pessimistic about when we'll be able to get going with this. Hopefully sometime in January, but I would have hoped that it'd be great to do it before the kids go back to school, so that we get a good big bulk of them doing it. Now, GPs are very likely to be crucial in that vaccination of children because of the very great difficulty vaccinating children in a mass vaccination type environment, and because of issues, for example, about getting consent in a mass vaccination environment and even in schools for this vaccine. So we are looking to GPs, I think, for a next push with regards to children. Now, there's these questions about these matrices and where these come from. These come from these things, the Work Permissions and Restrictions Framework for Workers in Healthcare Settings. And this is the national document with all these, what you're supposed to do based on whether you're vaccinated or not, and what you're supposed to do with regards to PPE in various situations. So to the question about are other states doing this? Absolutely. They're all basing their restrictions and their recommendations on PPE about this. Now, this is not a matter of just closing down a place. It's about people. It's about what they need to do based on whether they're vaccinated or not vaccinated, and what protection they need to do to actually protect themselves from minimizing their chance of actually getting COVID while trying to be able to maintain going to work. And really, that's the balance they're trying to strike at the moment. So this is what this document has come out from, and Emily's already spoken about this. And you know, obviously there's been a lot of work to try and get it to this point. Can I just reinforce a few bits from the last meeting? The first is that the cleaning requirements are very, very, very much toned down now and much more reasonable. And really, you don't need specialized deep cleaning. You don't need to take the curtains down and all that sort of stuff. And it's very, very much more reasonable. It's very clear in the document. So please read the document. And the premises will not be required to close unless you're advised to, or you can't clean outside of business hours. And obviously, if there are people in the waiting room, you might have to, but it's going to be relatively minimal in terms of the cleaning requirements now because of the reduced evidence for fomite transmission. Now, one of the things that the wording for the fit checking, if you're wondering, it's down at the bottom there on the charts. And if you have a look at the matrices, that's the important thing. Now, just have a look at this document. It's very important. A lot of people are getting confused. And I think a lot of people are getting really worried by this document because there are two matrices. There's one with vaccinated contact and there's one with unvaccinated contact. And they are saying that that's the person coming into the room. That's the unvaccinated, because the chart looks much scarier than the first one. So we'll go back to the first one, and that's the vaccinated contact. This is really the only one that should apply to you because you should all be vaccinated. You're the contact, your staff are the contact. You're not the, this is not the case. So you should have none of these people working in your organizations at the moment, unvaccinated contacts. So this chart almost doesn't apply to you. This is the only one that applies to you. And it is a lot less scary than that one. And I think a lot of people are basing their decisions about not allowing vaccinated people into buildings because they're looking at this chart, not that chart. So please, if you can just read it very carefully and understand the differences between the two matrices. This is the one that applies to all of you, assuming that everybody in your organizations is now vaccinated. If they're not, well, then they may be applied, but it applies to people, not the whole building. Now, the AMA is actually working quite hard to work out whether these are sustainable, these requirements for PPE and in the longer term, because realistically, in a very highly vaccinated situation, is it reasonable to continue with this? Omicron, unfortunately, may be the big joker in the pack. And obviously, we've got to find out whether it's more serious and whether it evades our vaccines, because that may change everybody's thinking about it. I found this really good picture in today showing if you have a look at it, the very marked, the red spots are the really high density areas with mutations. And you can see compared to Delta, there's a lot more on the Omicron strain, which is why everybody's a little bit worried about it. So just getting to national issues, COVID care in the community, as I said, really not great effort by the feds on this issue. And they really are just silly about it. They're just focusing on the provision of PPE to practices that are willing to look after COVID patients. And unfortunately, they just can't get out of their head that what we need is PPE that's sufficient to keep our places open for provision of all care for all patients in a COVID environment. I just can't get their heads around this, and it's really annoying. Unfortunately, they're not going to budge, and at this stage, that's a real problem. Their argument is that at the moment, and that the PPE is being released through the PHNs, but a lot of that is actually surgical masks, and it's not the PPE, the N95s that we really need at this moment in time, although obviously there is some, but the majority of that is not fitting with the matrices. So we have to align the matrices and the requirements to the PPE, but the feds just do not get this, and they are just fixated on this, that it's only going to be supplied to those providing COVID care, which is just not the model in South Australia. So I talked about PPE supply. So they're promising some independent PPE supply with N95s, but again, only to those places at this stage, that's my understanding, who are going to participate in COVID care, which is just, again, going to be something frustrating. So that's why it's good to hear that at least the state will help by allowing provision at cost at this stage for N95s. So I'm sorry that's the case, but unfortunately the negotiations were really badly done. The Commonwealth have this really fixed idea about how they want to run COVID care in the future. The item number for boosters is another big issue at the moment. We are actively working behind the scenes to try and get an increase. We understand that there's been an effective 25% reduction in the fee for the booster shots, which is potentially going to be a real problem for maintaining the momentum for the booster shots. We've actually, the OMA core sheet has written to the PM and the finance. Unfortunately, finance are only worried about submarines and making sure that certain areas are paid off for the climate agreements recently, unfortunately, and they're really not focused on this. And we have warned them that unfortunately it'll be probably around about election time with if things getting out of control if we don't get on with the boosters, and especially if Omicron becomes a problem. Look, getting back to this question, and I've seen the question about can a practice refuse to see unvaccinated patients? I'll bring that back again and say, look at the right matrix. So don't get quite so scared. But also what I would say is, just like anything, there is no easy answers. Nobody in this teleconference webinar is going to be able to give you a hard answer. We deal with a lot of uncertainty, and you always have in all your life. What we can say is that from an ethical point of view, you shouldn't abandon your patients, but you do have to balance the risk of, looking after that patient with the risk to yourself, your staff, and also other patients. The general position of the lawyers that we've spoken to, and again, this is not legal advice, is that it is problematic to have a blanket rule about this and to do that, and it may be viewed as problematic, and therefore, and again, I'm not going to tell you what may happen, but it's hard for me to make clear about it. But what is more important, in fact, that you try to do it on a case-by-case basis. And obviously, because of the stuff I said to you at the start about the increasing risk that they may pose, that you may want to consider, making sure that you apply, what's happening at some practices is that everybody is wearing fitted N95s with eyewear, with eyewear, and essentially that means that by the matrix, that should keep them above the bar from having to be furloughed in any way. So that's one thing you could do, but otherwise you need to look at everything else you can do, maybe provide care by telehealth if that's safe, but also potentially look at car park consults and doing anything else you may need, or see them at other times which may be not convenient for them. But what I would say is that's the general sort of thinking at the moment. Again, not giving you adequate legal advice, I'm afraid. Can you demand to see evidence of COVID vaccination? That's a hard one. And in fact, the AMA is going to be talking about that at the next meeting, because this is actually not an easy one. Just some ideas. There is a thing called the My Health Record, and there is a standing order that you can actually look at a person's My Health Record unless they tell you otherwise. So for medical reasons. So if they tell you that you're not supposed to look at it, you can't. But there is a standing order. The My Health Record was designed with legislation that you can look at that for health reasons at any time, unless you are specifically prohibited by the patient. And obviously, if they lock it. But that's just one thing you consider. In terms of what else we can do about the position, I have brought this question up at a federal level, and the federal people basically said, sorry, it's a state issue. So unfortunately, there is no easy answer at the moment, and I don't think that's something we're going to be able to give you a very clear answer, I'm afraid. I will just refer back to Health Pathways South Australia. A lot of the questions that are being asked, a lot of the resources are going to be available through Health Pathways South Australia, which is a link to a lot of them. So I'll strongly suggest that. And just finally, there's a few questions about telehealth. So the deal with telehealth is the government developed telehealth, and they always believe that it's for emergency provision. And currently it is still an emergency provision. The health minister has promised that he will continue it on, although that still hasn't been formally announced at this moment in time after the end of this year. This is in the context of this thing called the primary care plan, which is supposed to go on in the future, which I'm a little bit involved in, but there's a lot to go on in that area. Now, with respect to those other things, I would not be expecting that the government will be reinstating long consults to telephone or mental health items, I'm afraid. They believe that it's that with a highly vaccinated population, it's going back to where it was before. I'm afraid that won't be the case. They believe that, unfortunately, telephone is of low value compared to video, and they just won't budge on this issue, which is why I would be strongly advising, if you want to head down this line, to try and get to video at all, if at all possible. And I do understand that there are technical issues, and for a lot of people, but unfortunately, they will not be budging on this issue, or except for in terms of the mental health item, the only one that's available at the moment is the 2713, which is still available by telephone, but the rest are not going to be available. I do not see them budging in the longer term. They will be leaving it in video, but they won't be budging. The only time the long consult will be available if we get declared a hotspot, but we are, obviously South Australia is not declared a hotspot at the moment. So the C, the item C, will not be opened up for telephone unless we get declared a hotspot. So just to give you some thinking about it, but there is just that's not a battle we're going to win, unfortunately. So thank you.
Thanks, Chris. Very helpful. And I think you covered off just on the end there around the mental health item numbers when you were talking through that. I think that sort of covered. We did have quite a few questions around where telehealth is heading. And it's quite clear, isn't it, really, that it is a difficult space at the moment around where community transmission sits, what then happens in terms of activating additional item numbers. So we know a complex space. So thank you for providing those answers, Chris. I don't know if you want to add anything else on that.
Well, the thing is, they don't view that we've got, we're a hotspot at the moment, and they definitely don't believe that New South Wales or even Victoria are hotspots at the moment. So they're not going to do it for us at this moment in time. So really, the push is towards video, and I would be reading the writing on the wall as far as that's concerned. That's not going to shift. I think it's pretty much going to be the way it is at the moment for the future.
Thanks, Chris. I think there's quite a number of questions in the chat box, and many of these I've tried to answer as we're going through, particularly around different aspects. I did want to talk about the vaccine exemptions though for vaccine trials, because this has been a really topical question, and we had a significant number of emails through to the GP liaison inbox about this last week, and we try to provide out some clarity in the email as well that went out around the fact that it needs to be an active trial that someone is participating in, that where having a TGA approved vaccine is known that it's going to impact the outcome of the trial. And if someone meets that criteria, then an exemption can be completed and then sent off for endorsement by the CPHO. So, I mean, that's a good way, good in the sense that if you see someone come into your practice and they've specifically asked that, you can fill in the paperwork and send it off. It will be declined if it is one of those trials that we are aware of that are certainly circulating around in different forums and different areas that are not currently active trials, that where having a vaccine will impact the TGA ability for the vaccine, for one of the current vaccines to be given. But I think we're quite fortunate that we do have that ability to land back on the endorsement position as well, so that it's not all coming back to GPs in this space. So I just wanted to provide a bit of an update on that. And the other area has been around quite a number of questions. We'll start first a question for you, Tom, around antigen tests. And there's a question around the cost of antigen tests and whether, I guess as well, whether GPs should be considering around purchasing antigen tests as well, noting they're currently only prohibited for use, not for purchase. But what's the cost of the Abbott PanBio kit? I don't know if you can comment on that, Tom.
Yeah, sure. It's around $7 or $8 per cassette.
Thanks, Tom. And are there other types as well that you would recommend at all for GPs to be considering?
Look, there are a number. Roche makes one, BD makes one, and then there are a variety of others. We've done comparison tests with which the ones we're currently using. All of them will have some information about their sensitivity and specificity. But I'm reluctant to comment too broadly about the ones we haven't done comparison tests on.
Thanks, Tom. I know there's a lot of them available in different pharmacy spaces interstate, and so no doubt they'll be similar when we open up here around purchasing here in South Australia. So I think that'll be helpful when we circle back. I know that we can try and pull some information as well around sensitivity as well that's come out through the literature and where that's at. But noting that there are quite a number of TGA approved test types, and I think we've heard Tom talk about the Abbott test, but the Roche and the other types that also exist we know are very popular interstate. So we'll no doubt become more and more familiar with different brands and different types as we move forward now in this. We've had a couple of other questions come through. I think one in particular I might put to you, Jenny, if that's okay, around cultural sensitivity and awareness, and around where the GP assessment team is at in terms of managing complex patients or in the community, but also patients as well who may be within Aboriginal communities as well, and how I guess how you've prepared your team as well for managing patients in different community settings. You're on mute, Jenny.
Thanks. So yes, this is something that we've been, I mean, certainly in those at-risk groups or special need groups, we've had a lot more experience in some areas and much clearer pathways than others. So for example, we've been managing humanitarian refugees for quite some time with the Afghan refugees on top of that. So we've got lots of experience and lots of very clear defined pathways, how we involve the Rural Health Service in South Australia and how we onward refer if people are travelling and moving to other states for to take up residency. Likewise, we've worked on the model with the pregnant women above 16 weeks moving to Flinders for face-to-face assessment and extra support, and COVID kids for those complex kids. To date, we've actually only had one person who's identified as an Aboriginal or Torres Strait Islander under our care of GPAT in the hotel system, and that was last week, a young woman from the Northern Territory. So it hasn't been a group that we've had a lot of involvement with, but it did spark the conversation, and that we've started working on pathways and connections and links. So if anybody out there with experience in this area wants to get involved and have a conversation with me, that would be terrific, because we would really like to, I mean, people who are known to various community centres like a rural GP, we would be linking in with those services. The difficulty lies with people who are new to South Australia or don't have existing connections, and how we best address their needs. So it's a model that only Mel Smith and I were discussing earlier today. So it's a work in progress and very open to our colleagues who've got lots of experience in this area to provide some input and some support as we develop those guidelines.
Thanks, Jenny, and I think that'll be great. We'll make sure that we're connecting into AXA, and we're being really conscious that there's so many there's so many referral pathways already exist. We don't want to duplicate, so we'll make sure that we're connecting in that space. We've had other questions. I think the fit testing is just a question that comes up quite a bit, and unfortunately the guidelines make it a little bit confusing around the way that's been worded in the document. But to be clear, for the exposure matrix, it is around the fit checking as the minimum that you need to do for the matrix. Now, if we're talking about the PPE guidelines, the national ones that came out in May, June, that were updated by ISEC, the national group, we need to keep in mind here that it should be fit tested as being the gold standard for managing COVID, and particularly if you're caring and swabbing for COVID, it should be fit tested, because we know that provides the most optimum level of protection. However, for the exposure matrix, and we acknowledge that a number of people have not been fit tested, fit checking is acceptable. And following that guidance on the New South Wales website, for instance, the Clinical Excellence Commission video, a number of YouTube videos that are out there are really, really helpful to help instruct you how to fit check, and you should fit check every single time you put on a mask to check the seal and to make sure it is fitting your face. Now, if you've struggled and haven't found any masks that fit your face, I would strongly suggest reaching out to one of the providers who do the professional fit testing, as there are different masks that we can bring in as well through SA Health, and we do have a few GP practices that we have been supplying out masks to for quite some time now, where they need a special type of mask to fit a particular face shape. So please make sure that you are reaching out into those areas, and we can help do that through the GP liaison email address as well. Lots of questions coming through around in the rural space as well, and the plans for rural. And I think there's a country SAPHN webinar in next week, might be the week after, to talk through around where those plans are up to. And Mel Smith will be talking through that with a number of different people. But there is a number of plans in place, and I think there's been some really great questions come through. Not yet finalised a lot of these, but certainly the logistics and the transport are quite require quite a lot of work, and there there is work undergoing around bringing in different vehicles, vans, ways to transport people around so that we're not relying solely on SAS, particularly for well patients in the community. I think Jenny's gone through a lot around. Oh, Chris, fire
I've just
away.
got a couple of things. I stand corrected. So just with regards to just 2713 and the mental health treatment consultation at 20-minute one, that's a 92127, which is the telephone one. And also I stand corrected because there is actually one for the review of a GP mental health treatment plan, which is a 92126, which is the one for telephone as well. But there isn't one for the actual plan, first plan at this stage. And I don't think they'll be moving that because the view is, I think from government, that you actually do need to at least eyeball your patient with regards to doing a mental health care plan. And there probably is some significant argument for that. And now, the other thing I was just going to just say is, Belinda, you're absolutely right that you can check on air beforehand about, with regards to whether patients' vaccinations, and I completely agree with that. What I was just saying, though, is that the legal status of the My Health Record is very clear. You see, the My Health Record's got a legal framework that says that you've got a standing order that you can look at it unless they tell you otherwise. It is unclear what the status is of air, because air doesn't have a legal framework around it in terms of actually whether you can look on it. And obviously, if you don't tell them, that's fine. But you know, it is something that there is no legal framework at this stage. My view is that definitely use those two resources. I don't think there's anything stopping you, but just understand that. But the issue about whether you can ask them is a very, very difficult question at the moment. I don't think there's an easy answer.
And we had another question in around the GPMPs as well for COVID positive patients. And there's so many questions, isn't there, coming through around MBS IDA numbers, Chris, that I know you've been answering a lot of. I mean, I would suggest that people with, and Jenny will say this, people with COVID don't want to talk about things. They don't want to do things because they don't feel great. They feel a bit rubbish and a bit poorly. But Chris, any words of wisdom there?
Look, the world is going to be very similar to what it is now. I doubt it's going to be shifting very much. The government is extreme. What they've found is that there's been a significant increase in number of visits and this, and they are very scared about the overuse. And there has been on the numbers of what I've been seeing, and they do not view telephone as ideal, especially for longer type consultations, particularly for mental health, interestingly. And so despite a fair bit of negotiation about it, it's unlikely they'll be shifting on this issue. And this will be something we announce soon, and I suspect it'll be extremely the same. I would be strongly suggesting that you start moving towards video as much as possible if you can, and start to train your patients to use it as much as possible. I don't know. I mean, I've managed to get my mum to use WhatsApp, which has been pretty much a miracle, after getting her to use an iPad and prior to that, never wanting to use anything like that. So it's a sort of world we've got to get to at some stage, and that's the way that they'll be pushing us. There's no give on this one, I'm afraid.
Thanks, Chris. I mean, Jenny, you talked through around the different treatments as well, and I think really exciting now that there are preventative options, and we have both here in South Australia. I don't know if you had any wise words at all for GPs who are making comments around, you know, sort of how do we advise our patients around their eligibility or preparedness, particularly in the prevention phase, because they won't necessarily be straight under the care of the GP assessment team. They might be, you know, just someone that's worked out, they've been exposed, and to come in and are talking with their usual GP. So I don't know if you have any advice, Jenny, around some of these preventative options now that are coming onto the table.
Oh, Emily, you know me well. I'm always full of advice. Whether it's useful, it's the question. So, yeah, look, I think we've talked a lot about this too, because these people that come in who might be in quarantine at home won't necessarily be known to us. They will sit under the contact management team at CDCB. So we've talked around how we would identify who would be at risk, and they are given a home quarantine app which records things. And so part of the discussion is about flagging you know, the questions on the app that would then identify these people. But in the short term, really the only people we would be looking at providing post-exposure prophylaxis too. If I take this from David Shaw's mouth yesterday, I think, from infectious diseases, is household contacts. So we will know those because we will know the COVID positive, and we will have access to that family's situation and household structure, so that they will get picked up there. Now, that's the initial focus, and I guess it will depend as we move forward on numbers and availability of the various medications, which we do have access to. So, but for now, it's around household contacts, and we have got the app and a series of questions, a really simple, that's almost finalised, that can identify potentially those people that meet criteria. And then what we will be doing is on sending them to infectious diseases, who will approve or not approve, and then we will be able to go back to those people who might be in those groups to say, hey, look, you are in this group that could have this, would you like to? And then we would begin that whole informed consent process. But at the moment, just household contacts as a starting point.
Thanks, Jenny. There's quite a number of questions. I know, Chris, you just answered in the chat as well around this whole concept around not seeing unvaccinated patients. And I know there's been a lot of back and forth on social media around this. And all we can do is really provide advice around different alternative ways to provide care safely. And I know I put in about the medical board, because the reason why I did that is because of the fact that people keep saying, but what's my obligation in terms of my registration? Will I be reported if I refuse to see a particular person? But I offer them an alternative care pathway. I say, I'll refer you to the respiratory clinic, or refer you to this space, and you document it. I think it's really quite clear that that is acceptable if you're going to document through the rationale behind why you haven't provided that face-to-face care, the safety, the concerns, the vulnerability, but you've referred and provided alternative care options. And there was a really great article that had been put together. I think it was Leanne Rowe put it together, and I copied it into one of the recent GP updates, because it is an area. It's not that we're trying to tell you what to do at SA Health. We're not doing that at all. We're trying to just provide that advice out. We've been inundated with comments and questions around this area. Jenny, did you want to? You put your hand up as a panelist, Jenny.
I know. So no, I think that's something that is out there, and it's interesting to hear the conversations about GPs making those decisions, and talking to colleagues, and then about how that's perceived by patients, community, people outside of general practice, about whether it's appropriate, inappropriate. But I think a lot of it's around fear and not understanding the full details. And I think, Chris, you were really put that really clearly, is it's very easy to get bogged down in lots of those different if, what if, but it's really one that applies to general practice. If all your staff are vaccinated, which they will be, or they won't be at work, then it is really clear how that works. And so I think that fear is about, people are worried that if they do the wrong thing unknowingly, and then their practice will be shut down for 14 days. And then that's, it's such an enormous impact on livelihoods of everybody and patient care. So I think if we really understand the clear guidelines around that, then you're making informed decisions. I think there is a lot of misunderstanding, and perhaps people have been really looking for that clarity around how it all works. And I think, Chris, you put it really well in that one slide. So I think it makes it clear to everyone what it means.
There are some things we cannot be sure of. We do not, look, just like I've got this person trying to send me to the Human Rights Commission about saying that let's be realistic. The bottom line is we can't be sure. There's no real proper test case in this situation. I think what I'd have to say is you try not to abandon your patients, but you do have to balance your risk to yourself. It's no good. You're no good to other patients if you get knocked off as well, in terms of actually being taken out of play, obviously. But then they would ask you, why didn't you use your proper PPE in seeing patients? So there's going to be this tricky balance you're going to have to think. Unfortunately, medicine is like this. There's so many other areas. This is not the only one. But what I would say is, I think that where you have a bigger potential issue, that is potentially if you just have a blanket rule about it, because that may that without any clear reason, that may be more of an issue at that stage, unless you could actually justify it. And obviously, a very key part is communicating to all your patients at all time about what's actually happening. So I think that's what I'd say to you. It's where you understand ethical responsibilities, but you do need to consider also, what the perception would be if you just have a blanket rule in that situation. The question to that, David, that's exactly right. Then do we need to keep all clinicians who have patient contact, practice nurses visiting, again, look at the matrix and work out what those people are going to do and how critical they are for you. You have to actually work out how you're going to manage your, it's a question of managing your, where are your, who are the people in your staff, how are you managing your patients and how long they're going to stay in a particular place? Because if you look at the matrix, it's got to be how long they're there, how close they are, how big the room is, and how long they are in contact. And you need to actually work out your staff, and that includes doctors, nurses, your frontline staff as well. Do all your things like, making sure they don't stay in the waiting room for too long and that sort of thing. But ultimately, the main thing is that you have to decide then, based on that matrix, what PPE you want those people in if they're critical. And if they are really critical, they probably do need to be in as much, that minimum bar, which is again, which is the bar is fit checked N95 plus eyewear is the bar, unless you have to touch them, in which case you need to use gloves and wash your hands and all that sort of stuff as well, of course.
I think the other thing too is that as we move forward, we're getting more guidelines. So the Women's and Children's is saying that pregnancy visits under 20 weeks can certainly be done via telehealth. That 28-week visit might require a face-to-face. So there are, in various specialty areas, some guidelines. I'm really looking forward to putting that sign on my door that says, due to COVID restrictions, I need to keep my consults to less than 15 minutes. I am just so excited about that one. How I'll actually make that happen, I don't know. But that's where I'm greatly excited.
Thanks, Jenny. I've tried to get through as many questions through the chat. Of 75 we've answered, so there we go. We've managed to get through quite a few, but there still are a number of ones coming. And I know that there's always going to be questions. We're always very happy to have questions emailed through to us in the GP Liaison email address, and we can send them through to Jenny. And of course, if you're interested in being part of the GP assessment team, we'd love more rural regional GPs who just want to do a little bit of work, or maybe just want to know more about the GP assessment team and what we're doing and how we're supporting across the state. Of course, if you've got specific AMA questions, Chris questions that only Chris would know and has so much insight into, then we can forward them on to Chris as well. And then, of course, Tom with antigen testing, test times, anything you need to know about that, we can send on to Tom Dodd as well. So a very big thank you again to Adelaide PHN for hosting tonight's webinar. We've tried to cover as much as we can, and of course there's always going to be more topics to talk through, and as we see more cases here, sadly, we'll have more to talk about as well around referral pathways, where we're up to. We'll finally be able to use some of our sotrovimab, or we'll see how we go with using our IV monoclonals, and we'll be able to then provide an update out as well. So lots happening in this space. We're here to support you, and all the best. Take care, everyone.